Hi rehabbers, so this week's learning is all things lateral hip, and this training is going to consist of 4 videos, 2 a week being released. So today's video 1 is what is GTPS, what are the risk factors, the differential diagnosis of lateral hip pain and how to assess the lateral hip. Video 2, which will be released later on this week, shows how to treat GTPS, so what patient information and exercises should be given to our patients with this condition. Video 3 for next week will be releasing on what treatment adjuncts are, what they can be offered, including steroids, PRP injections, dry needling, shockwave, hormone replacement. And then the final video will be how to read a hip MRI for GTPS and what does GTPS actually look like on a MRI scan. So, what is greater trochanteric pain? It is usually not one single condition, so it can consist of multiple different things, such as tendon pain from tendinopathy, partial tendon tears, from bursitis, from things like snapping hip, where the ITB flicks across the greater trochanter, which is seen in ballet dancers. It can be myalgia of the gluteals. It's more common in ladies than men, something to do with the orientation and shape of the pelvis and the greater trochanters, but it's usually in favor of 3-to-1 for females, and more common in the 40 to 60-year-old range. It has significant functional limitations on our patients, with some studies showing that patients with significant GTPS report the similar functional disabilities to those waiting for total hip replacements with end-stage hip arthritis. And also our rehab does not seem to be working in that 11-year follow-up, 45% of patients that had GTPS initially still had it 11 years later. Although it's really important to know this was a study looking at natural history and was including very small patient numbers. The risk factors, so apart from obviously sex related, so studies show that females have nearly 4 times the odds of developing GTPS than a male does. But there are also comorbidities, so diabetes, high cholesterol, high blood pressure. Now, this isn't to say that this is a causal link. We cannot say diabetes causes GTPS. What we can say is patients with diabetes have just over a 49% increase in odds for developing GTPS compared to those without. Likewise, people with high cholesterol are just over 19% increase in odds of developing GTPS compared to patients with normal cholesterol. And then finally, patients with higher blood pressure have 10% increase in the odds of developing GTPS compared to patients with normal blood pressure. Now, what we don't know is, can these all be added up and do they increase the risk further? So a lot of patients we all see have multiple comorbidities. Many of my patients will have diabetes, high cholesterol, and high blood pressure. But there's no research currently about adding these on and seeing what happens. So we can explain this with a patient. Now, this is one of my patients. Debbie's not her real name, and the photograph is not her real photo. But Debbie started with right lateral hip pain, which she noticed after doing couch to 5K. Her symptoms are worse by walking, sitting cross-legged, going upstairs, laying on her side. Things like stopping her aggravating factors, pain relief, ice, eases it pretty quickly, and a 24-hour pattern. Sleep is disturbed when she lays on her side, but there's no early morning stiffness. And comorbidities include high BMI, diabetes, and the menopause. So what we can do here, you can pause the video and you can write down the things that you would think could be in the differential diagnosis and why, and then when you're ready, just press play again. So the differential diagnosis, the key main ones here are gluteal tendinopathy, hip arthritis, and spinal referral as a possible cause of GTPS/lateral hip pain. This is a good study by Grimaldi, which you can have a look at in your own time. So what should we test when we have our patient with lateral hip pain? So generally, most assessments would include lumbar spine range of movement, palpation, your neurological assessment, so your myotomes, dermatomes, reflexes, straight leg raise, hip range of movement and strength, hip muscle length testing, GTPS testing and palpation, and that will help us then start to differentiate. So if, for example, our patient has no back pain, no back pain on range of movement testing, neurology's fine, and spinal movement doesn't reproduce the hip pain, then we're not thinking it's a spinal referral. Likewise, if the patient has good medial lateral rotation with no capsular restriction, then I wouldn't be thinking it was arthritis. Likewise, if she can put her shoes and socks on with no problem, then again, I'm not thinking arthritis. Now, my patient didn't have lower back pain, the range of movement was fine, neurological assessment, straight leg raise was all fine, hip range of movement was fine, strength was a little weaker in the gluteals, hip muscle length testing like the OBA was actually okay, GTPS testing and palpation was what reproduced this patient's symptoms. So the key diagnosis there would be what test do we use to look for this. Now there's another video already been done that shows you how to assess and can do the neurological assessment when you're looking at this, but this last part will be about the actual tests for this. So this is all based on a paper by Kinsella and colleagues in 2024, and we'll see if the videos play.
Okay, so the first test for GTPS is Greater Trochanteric or Greater Trochanter palpation. So all we're doing here, once you've got consent, obviously, is have a little feel of the Greater Trochanter and palpate around the edge. And a positive is a reproduction of the patient's lateral hip pain. While we're here, I also check for general myalgia of the gluteals. So this isn't part of the group of tests, but generally some light pressure along the gluteals, along the TFL, just to see or have a little feel of the muscles. So the second test is the derotation test. So what we do is we bring the patient up into 90 degrees of flexion. We then bring them in to external rotation, and we then just take the pressure off slightly so they're not on full stretch, and then we get the patient to internally rotate. So Ness, when I say go, I just want you to bring your bit back like that for me. Okay, ready? Off you go. And a positive is a reproduction of the patient's lateral hip pain. And the third test is the Faber's test. So again, I generally put the patient's foot just under their kneecap, and then we just drop the leg gently down with control. And a positive is a reproduction of the patient's lateral hip symptoms. If the patient gets pain in the front of the groin, that's not positive. And if they get pain around the SIJ, that's not positive either. The next test is the resisted hip abduction test. So we put the patient into hip adduction side lying, unaffected or untested side out the way. And then next, when we say go, I just want you to lift this leg up into the air for me. And then push up and then relax. And a positive is a reproduction of the patient's lateral hip symptoms. So the next test is the standing test. So Ness is going to put fingertips on the wall or door for support, standing on her bad leg, which is the test leg, and then bend your good knee. Just bring your knee back a little bit. That's it there. And we're just going to hold it in that position for 30 seconds. And a positive is either poor balance and needing more support, plus symptom reproduction here. And the final test is the Trendelenburg test. So what we do here is patient still in the same position, so very light pressure on the wall. And she's going to bend her other affected side, just bring the knee back slightly. And what we're looking at is to make sure there is no pelvic drop. So if we find, when she takes this leg off, that this drops, it basically means that the hip, the testing hip, can't control it. So we will need to maintain a position of your pelvis for 30 seconds. It'll either stay the same level or slightly come up, but it shouldn't dip. If you can't control that for 30 seconds, it's a positive test.
And what the study goes on to show is that if you add certain tests together, it can affect the probability of the diagnosis. So what they found was if you had pain on palpation of the greater trochanter and pain on resisted hip abduction, then the probability of having GTPS is around 96%. Whereas if it wasn't painful on palpation of the lateral hip, resisted hip abduction was not painful, then the odds of having GTPS is significantly reduced.